Thank you very much, everyone. It's great to be here. I feel like I'm somewhat out of my natural environment here. I'm a librarian by profession, although I've not worked in a library for 15 years or so. So I'm an information specialist at NICE at the moment. So NICE is the National Institute for Health and Care Excellence, and we produce guidance for England. Some other guidance applies to the rest of the UK, but most of it is just for England. We're actually on version 3 of NICE at the moment. So we were established in 1999, and the purpose then was to give fair access to pharmaceutical products. In 2005, we were given more responsibilities for public health, and in 2013, we were given similar responsibilities for the social care sector. So the whole purpose of NICE is to produce evidence-based guidance. Okay, so the responsibility of my team is to find that evidence on which we'll base the guidance. So I just want to run through the search process to give you an idea of what we do to find that evidence, and then I'll go on to show you some examples of the kind of work that we're working on at the moment. So very simple model here, something much simpler than the presentations in the first session, but this is kind of what we do. So we write a protocol, because everything that NICE does has to be transparent. So how did you find this evidence? Make sure that we didn't cherry pick the best evidence. So we explain the rationale of what we're doing, we list the sources and the methods that we'll use. Once we've done that, we'll develop a search strategy, we'll test the strategy, and then that goes through a quality assurance process. Once we've completed the strategy, we'll adapt it to other sources, we'll check those adaptations, and then we'll run the searches. In the fourth stage, we'll process the results. So everything has to be downloaded, remove the duplicates, record what we've done. So all of that standard kind of admin work as well. So putting that into practice, this is the kind of work that we did. We still do it now, but this is what NICE did in 2000, 2001. So you might have a drug, Gemcitabine, for treating pancreatic cancer. This is the kind of guidance we would produce. So we would write the protocol, develop the strategy. In this case, the strategy would be fairly basic. So, your standard kind of Boolean search, Gemcitabine, which is also known as Gemzor. So we combine the two names with terms of pancreatic cancer, cancers of the pancreas, neoplasms of the pancreas. It's a standard Boolean approach. You can make it more complicated if you want particular types of evidence. So if you wanted, say, randomized control trials, there's validated ways of finding those, but it's all fairly straightforward. Search the databases with that strategy, and then we might look at other sources. Other sources tend to be unpublished data from clinical trials, and then we need to complete the search, write up the search, so we do the processing. So it all flows pretty well established. If you remember, I said the remit of NICE has changed quite a lot over the years. So the public health searching takes a very different approach. It's with the clinical trials, there's a certain amount of trials that have been completed, and it's our job to find that set number of trials, whereas in public health, social care, it's much more interpretive, more iterative approach. Some of the stopping rules we discussed earlier would apply to this kind of question. So this is a kind of question we might have. Which campaigns delivered through digital media are effective and cost-effective in preventing take-up of smoking in children, young people, and young adults? So there's a lot going on in this question. So let's break it down a bit. So Campaigns delivered through digital media. So we need to work out what is a campaign, what does digital media mean? It's not immediately obvious to me. Effective and cost effective, that might mean 2 searches, it might mean 1 big search, something to establish. Preventing take-up of smoking, so we're not looking at cessation for people who already smoke, so that's a different literature. And the final element was a really interesting one. In children, young people and young adults, children's okay, young people, we can define. Young adults, they wanted papers for people up to the age of 24, and it's quite difficult to find literature specifically on people aged 18 to 24, so that was quite a challenge. So you can see a lot of the question and dealing with the search is not what goes on the database, it's working out what does the question mean, what do they really want from this process. So if we go back to our model, I wasn't starting from a blank page, so we had guidance on smoking prevention that we published in 2008. We did surveillance in 2016 that said this guidance needs to be updated. So I had 2 previous searches that I could use, so I had some background information. I wasn't starting from a blank page, and I could feed that into the draft protocol. But what's missing from the model so far is this next step. So the review team are the guys that would review the evidence. So they write the report. So when I spoke to them about the draft search and what do you actually mean about digital campaigns, we had some really long, in-depth discussions about what they meant, and I'd included text messaging, because there's quite a lot of papers about if you use text messaging to remind people about not smoking or stopping smoking, that's quite effective, but apparently that was not the kind of digital media that they wanted. So we had to revise the search there. Went through to my QA stage, and the QA said, well, you're talking about smoking, but I just used tobacco. But are you talking about e-cigarettes and vaping here as well? So that was another question where we went back and had some discussions about that, about the scope. And then when we got to the committee stage, so the committee are the people who make the actual recommendations, what they were saying was they wanted to make a distinction between interactive digital media, so Twitter, Instagram, Facebook, YouTube, those kind of things, and that's what they were interested in. And they were less interested in apps that had been specifically designed to download to prevent children from smoking. So it's quite a subtle distinction, one that I hadn't picked up from the initial request, but you can see it's a much more interactive process that goes on in the guidance development. We have our search, we test and adapt, as I've said. Topic sources, so where do we search, is something I'll return to shortly. So we need to run the search, record what we've done, and then report the results. So rather than this 4-stage model of 4 arrows pointing in one direction, I prefer to think of the search more like this. So we have the much more interaction between the different elements. We might get to the strategy stage, go back to the protocol stage. We might reach the searching stage, go back to the strategy stage. So it's a much more interactive, iterative, and for me, it's a much more interesting process. And just to give you some context, the pharmaceuticals, we might do 12, 13 searches a month. This kind of public health, we might do 5 or 6 a year. So quite a different amount of work involved. Okay, I want to just move on to some of the developments we've been looking at recently. So this is a chart of the source of evidence for some public health guidelines. So we looked at how would we found the evidence in 10 public health guidelines, and those 10 guidelines have 29 different reviews in them. If you look at the medical literature, you quite often find that they search PubMed, and if they've only searched PubMed, we wouldn't call it a systematic review. We would expect to see a wider range of sources. PubMed, Embase, Cochrane Library are the ones you're most likely to see. So what we wanted to say, what we wanted to find out was whether these 3 core medical databases provide us with the evidence. And what we found in our sample was that these databases give us about 77% of what we need, so just over 3/4. So we'd be losing 1/4 of the evidence if we only searched those core databases. There's about 11% from the light purple there from other topic specific databases. So we might search PsycInfo for a mental health topic, CINAHL for a nursing topic. There's a database called Transport. Why would I search Transport for a pharmaceutical topic, but I'd have to search for an environmental topic? So this is not about using a core set of databases for every review we do. This is about tailoring what we do to the review. The rest of the evidence you can see here in the kind of green color is from non-database sources. So this is where we've used things like citation searching on Web of Science or maybe Google Scholar, reference checking, contact with experts, a whole range of non-database methods. Might be unpublished data. So you can see that makes a significant contribution to what we're doing. So it's not just about the database search, it's about the location of that search. I was really interested in the previous presentation when Paul mentioned that the 16th of March was a key date, because the 16th of March was a key date for NICE too. So on the 16th of March, we were told you have to do some COVID-19 guidelines. And by the end of April, we'd published about 20 guidelines. And if anyone knows NICE, it can take us maybe 2 years to produce a guideline. So to produce 20 in 2 months was quite an achievement for us. Since we've published those guidelines, we've been monitoring the evidence. We've looked at about 100,000 records since beginning of April. From the blue bars, there's an average, we download about 3,000 a week. So how have we managed to look at 100,000 records in 8 months? Well, the answer to that is that we haven't. We've looked at about 70,000. And the teams that I work with, they can manage about 1,000 records a day. So if we're cutting it from 3,000 to 2,000, we're making a significant saving each week. And the way that we've reduced by 30% is by using what we call priority screening. So I'll show you what we're doing. This is not from COVID-19, this is from a psoriasis topic, but this shows how we normally do the screening. So across the X, you can see from here, we've screened just over 300 records. And you can see there's a diagonal blue line. So the blue line shows how many relevant papers we found within our search results. And you can see just over the dotted red line is the halfway point, and we have about 65 of the 115 papers. So we've done about half of the screening, found about half of the results. So the results are within proportion to each other. What's much more interesting is the next chart, which is where we've turned on the priority screening, which is we're using in Epi Reviewer, which is built by James Thomas and the team at UCL. So we're using their technology for this. This is a conjunctivitis topic. So again, not COVID, but it's the same technology. So on this occasion, we screened 3,300 results, and something you can see, this is not a diagonal line. This is much more interesting here. So the first section here from 0 to 330 is a straight diagonal line. This is a random sample of 10%, where the machine learning is learning what do I include, what do I exclude from the results. You can see it's switched on at 10%, and by the halfway point, the red dotted line, I have 99% of the relevant papers. There's one towards the end that wasn't particularly relevant when I checked in more detail, but you can see by the halfway point, we've got 99%. And if you look towards the beginning, I had half of the relevant papers after I had screened 13% of the results. So that machine learning algorithm, it's a simple bag of words approach, nothing particularly sophisticated. You can see it's making our screening much more sophisticated. There's a discussion to be had. Did we need to screen all of these results from 1,500 to 3,300? Did we achieve anything by looking at those? Would it have been safer to set a threshold and not look beyond that threshold? So there's lots of discussions going on. Where would we set the threshold? Some people say 75%, some say we can take it down to 40%. So those are the kind of discussions we're having at the moment. So just to round things off, as I say, NICE has to be transparent, and these are the methods that we're told to follow. So this is the manual that's on the NICE website. It has 2 sentences. I just want to draw your attention to the 2 sentences here. So the systematic identification of evidence is an essential step. It's the word systematic is the interesting one. Systematic has traditionally been held to mean comprehensive. You found everything, and we've dealt with all of the evidence. If you read it in the context of the second sentence, the aim is to identify the best available evidence to address a particular question. So it's not saying you must find all of the evidence, every last single piece of evidence that has ever been published on this topic. It's the best available evidence within the time and the resources available. So when we produced those COVID guidelines, we had 2 months, and we had to, it was more important to produce the guidance in time than to find every single piece of evidence we might have used. And that's the kind of approach that we're taking. So we try to be systematic and transparent, but we have to make some pragmatic decisions. We can't produce unmanageable numbers of results, but the way we deal with the number of results has to be transparent, and we have to show people what we're doing. So there's quite a lot of thought at the moment going on into that kind of approach to searching, approach to evidence. That was a really very quick whiz through some of the things that we're talking about. I'm really happy. Obviously, there's questions now, but really happy for anyone to get into contact with me to talk in more detail. The book that Martin mentioned at the beginning, Systematic Searching, published with Jenny in January 2019. It's aimed more at the information specialist running database searches, but the introduction covers some of the models I was talking about and our approaches. I have an open access version if anyone on this call is interested in seeing that introduction. And I'll stop there, Martin. Thank you.
Oh, thank you very much indeed. Fascinating stuff, and a nice match to what Paul was talking about in the enterprise setting. Questions. Dave Newman, is EPI Reviewer a practical proposition for a single health library doing literature searching for users in terms of cost and usability? That's something you can comment on?
Cost, I have no idea, to be honest. That's way out of my my knowledge. Usability, EPI is designed for managing reviews rather than managing search results. So it's not quite, it doesn't have some of the functionality that we need. So we did a lot of work with James and the team on the deduplication algorithm, which is a fairly standard thing in things like Mendeley EndNote. So I'm not sure. They're quite happy to give demonstrations. So if you're in a single library or a small team, I'm sure James and that team would be happy to give you a demo.
And from Tony Russell Rose, are you looking at any other automated means of helping? As that EPI work sort of stimulated the thought that, yeah, this would make a difference? And are you looking at other techniques?
So yeah, so there's a whole movement at the moment to automate the whole NICE process to see what efficiencies we can save across the whole process, from identifying the evidence, screening the results, picking out the relevant points for the reviews. And we're interested in things across that whole range of activities. I'm not sure if it's a concept that you're familiar with, but one of the big things at the moment is something called a live-in systematic review. So NICE has traditionally, or people like Cochrane Collaboration, we've traditionally done a review, we've published the review, and 2 years later we say it's time to do an update. So it's very much seen as a static product. But what we're trying to do is this live-in approach. So we're constantly updating, and you can see with the COVID-19 evidence, which has been published in such a tremendous volume, that if we left the guidance for 6 months, it would be quickly out of date. So we need to be feeding evidence into the process almost on a weekly basis. So anything that would automate that process is something we're interested in at the moment.
Two questions, sort of asking the same question slightly different ways, but I'll take from Jeremy Pickens, who's an e-discovery specialist at OpenText, and we'll be talking this afternoon. He says, I get the best evidence is not the same as all evidence, i.e. high recall, but couldn't one say that it's all evidence above a certain quality threshold? In other words, you still have to take a recall-oriented approach, and that blends in with a comment from Elaine Toms, is what's that criteria for evidence? It starts to get, I think, quite subjective in terms of that. How much is that adding to the base of knowledge? Is that something you struggle with?
It certainly is, yes. It's not something that I could give you easy answers to now. It'd be great to have a full discussion about those. In the typical kind of Boolean world of search and Medline Embase, those kind of databases, there are validated search filters that we would use. So if we were looking for randomized control trials, observational studies, that kind of thing, there's validated ways of doing those. One of my colleagues, Linda, has done quite a lot of work on how do we limit search results to UK evidence, or how do we limit to evidence from developed countries. So the kind of search I was talking about with the tobacco and smoking, the contextual information is really important there. So if we had a study from Manchester, that might be relevant to people in London. If we had a study from Paris, that's probably relevant, but a study from Tokyo, is that relevant to the UK? We're not sure. So the contextual information is always really important in what we're doing. So yeah, it's the quality of the evidence is something that NICE spends a lot of time looking at, thinking about. Once I've handed over the search results, there's a lot of effort goes into that next stage.
To what extent, and this comes from me talking to a big multinational the other day, what threw them in their sort of COVID-19 searching was that they were having to cope with material that was not in English, because the German guidance is in German and the Spanish guidance is in Spanish. To what extent do you look at other languages to see what codes are being developed in other countries, particularly around Europe, or in the case of COVID, China?
This was a really big thing for us. So in March, April this year, it was not only the volume of evidence, it was the types of evidence that we were looking at. Language is really important. So NICE generally, we're quite, I don't know what, I'm glad that you stopped recording at this point. I don't know what the word is, but we tend to look at English because that's what we can understand.